The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Good afternoon, and welcome to the last webinar in our four-part series on safe sleep, enhancing your hospital's safe sleep practices. I'm Eva Fassbinder-Brummel, and I'll be your moderator today. So let's get started. This session is being brought to you jointly by Children's of Wisconsin and the Wisconsin Association for Perinatal Care, and there is our contact information should you need to refer to that at any time. And we do want to appreciate the work of our planning group for this educational series. Members of this planning group have no relevant conflicts of interest to disclose. And we are honored to welcome 4 faculty members today: Stacy Allen, Colleen Fury, Ann Grip, and Kathy Jablanowski. And they are all colleagues that work together at Children's Wisconsin. They've been working on this issue of safe sleep for nearly a decade. I'll let them introduce themselves in a minute and talk more about their roles there at Children's with safe sleep. And so some other disclosures we need to show you for your reference and some information about what the requirements are for continuing education. Just a reminder that you do need to attend the full session and complete an evaluation via SurveyMonkey that's sent to you after the session in order to receive that continuing education credit. So just watch for that. And our learning outcome today, participants will be able to identify 2 behaviors to model safe sleep in the hospital. And just want to go over a couple things before we begin, just that you as the audience will be in listen-only mode by default. So you will be muted the entire time unless you raise your hand, which signals to me that you would like me to unmute you in order to ask your question directly. So just note that hand icon in the upper right-hand corner of your screen. If you don't see it, you just click on the orange arrow and you'll have a bunch of different options open up to you. We do encourage you to ask your questions by speaking directly to the presenters using your phone or your computer microphone. For this session, however, we're going to wait until the end to do any unmuting for questions and discussion. So if you have a question that you really want to ask or a comment you want to make directly, we're going to wait till the end to do that. But at any time during the session, you can ask questions by typing them into the question field. So you can use that again at any time. I will communicate those questions or answers to the presenter in the order I receive them. And for those, like I said, we're not going to wait till the end necessarily for those written questions. So we'll just ask if time allows during the session. If you don't see that question pane, just expand your screen by clicking on the orange arrow and you should see that question pane. Just click on that. If we don't get to your question due to time constraints, WAPC staff and the speakers will respond via email following the session. So if you have any questions, just email them to wapc@perinatalweb.org. If you're having any technical problems at all, it's best to contact Barb directly at the office, who's ready to troubleshoot any issues you might be having. Her number is 608-285-5858, and her extension is 201. Okay, and with that, I'm now going to turn things over to Ann. Ann, go ahead.
Okay, thank you so much. Children has concepts that to support our values. One of them is appreciation. Thank you for the opportunity to share our safe sleep journey with you. We hope you glean strategies to support your own journey with the Impact to National campaigns. The 4 of us each bring a different lens to safe sleep. Stacy is an acute care nurse and the co-chair of our Quality Improvement Council. Kathy is an NICU nurse and a safe sleep champion. Colleen is a patient safety specialist in the organization and has led our work related to our Safe Sleep Champions and is integral to our steering committee. And myself is a clinical nurse specialist in the NICU and happens to be the co-chair of our Infant Safe Sleep Steering Committee. So Children's Hospital Wisconsin has changed its brand and logo to be Children's Wisconsin because they want to change the impression that we're not just a hospital. We have 40+ locations, including 2 million touch points in hospitals, clinics, schools, homes, community, and online. Next slide. So what do we hope to share with you today? We want to ground us in definitions on SIDS and SUITs and the triple risk model. We want to share with you our data and our purpose to the why this work is important to us. Share our safe sleep journey. talk about the tenets of safe sleep in relationship to barriers and processes, share our Safe Sleep Champion process and how we audit, share with you as well our staff and hospital barriers and improvement strategies related to those. Want to talk about how we improved our safe sleep messaging, education, and practices, and share some resources.
Anne, we're getting a comment that some people are having a little trouble hearing you. So if you could just try to enunciate or speak up a little bit, that would be awesome.
Sure.
Okay, thanks.
So sudden unexpected infant death, or SUIDs, is a term that's used to describe any sudden and unexpected death, whether explained or unexplained. So it's an umbrella term. After each case investigation, SUIDs can be attributed to suffocation, asphyxia, entrapment, infection, ingestions, metabolic processes, cardiac arrhythmias, and trauma, whether that's intentional or non-accidental. And so safe sleep is a part of prevention. In 2017, the CDC reported that we had 3,600 deaths categorized as SUIDs. And then SIDS. SIDS is a subcategory of SUIDs and is a cause assigned to infant deaths that cannot be explained after a thorough case investigation, including scene investigation, autopsy, and review of clinical history. Of those 3,600 SUIDs deaths, SIDS accounted for 38% of those deaths in 2017. The triple risk model is a model that explains SIDS. It poses that a vulnerable infant at a critical period of development, when exposed to an external stressor, which they may be unable to cope with, may die from SIDS. There's a critical developmental period where the peak incidence of SIDS is between 2 and 4 months of age. 90% of all SIDS deaths occur before 6 months of age. Infants continue to be at a higher risk for SIDS up to the age of 1 year. Outside stressors include secondhand smoke, inappropriate bedding, overheating, and sleep position. Stomach sleeping encourages the rebreathing of carbon dioxide. In that vulnerable infant, a great deal of babies that die of SIDS have some sort of upper respiratory infection. Babies born early are at higher risk. Some research shows that at the time of death, some SIDS babies have an increased levels of serotonin. Both stomach and side sleeping increase the risk of SIDS. The risk is increased further in low birth weight infants, preterm infants, and infants at the age of 13 to 24 weeks, suggesting that SIDS may be triggered by stomach sleeping in infants with prenatal risk factors. Risk reduction means removing as many of the challenges from the baby's environment as possible during that critical first year of life, and hence that's where our tenets of safe sleep originate.
So for the next section, we're going to cover 4 topics in our data and purpose section: a champion story, Wisconsin infant deaths, community infant deaths, and our purpose, the why behind we're doing this. As we move into the next section on data and purpose, we acknowledge that while numbers and statistics are important to share, it's also just as important to make sure we're making these numbers personal, as they are someone's baby, daughter, son, niece or nephew, or grandchild. Because again, personalizing it, what if someone you cared about were one of those statistics that we're going to talk about today? We begin each of our safe sleep meetings with our champions with recent events that have happened within our walls. It's important to personalize the data to understand the magnitude of our impact. So next we're going to talk about a safe sleep champion story. In thinking about our impact, we wanted to share a story with you today that was shared very recently to us by one of our champions. One of our agenda items in our last Safe Sleep Champion meeting was the power of storytelling and how impactful it is for staff to hear about real events that have happened, and one of our champions shared her story. When we initially recruited for Safe Sleep Champions, we sent out a message to all unit leaders asking them to identify a champion, someone who would be passionate about this work and helping to change a culture. One of those champions that was identified, or actually volunteered, was a nurse on one of our units named Gina. Gina was taking care of a baby in our hospital, and the patient had a good outlook. Just like so many of our families, Gina had developed a good relationship and bond with the family. After a few weeks, the baby was healthy and ready to go home and be discharged from the hospital. As caregivers, we realize how fortunate we are when we get to send patients home and celebrate that they have healed, as we know it doesn't happen for every family. Several months later, Gina, who also happens to be a mom with 2 kids, happened to be watching the news at home before her next shift. The information she heard on the news immediately made her pause, and the emotion that followed was tough to handle. She recognized the name and saw the parents of that sweet baby she had cared for almost a year ago, and learned that the baby had died of a co-sleeping death at home. The effect this had on Gina was beyond what any of us can imagine. She questioned if she had done enough to educate the family on safe sleep while they were in the hospital, and made it her mission to tell staff her story and how vital it was to educate families for when they go home. Thus, when Gina heard about the opportunity to be a Safe Sleep champion, she jumped on board and has been a pivotal member of our team in helping to change our culture. This happened to this nurse several years ago, and yet she told her story as if she saw this news story yesterday. By teaching families to understand and adopt safe sleep behaviors, we can hopefully prevent unnecessary tragedies from happening in our communities. We would encourage all of you to talk to your staff and listen to their stories, as it is a tool that can be used to connect everyone to the data and personalize the safety piece of it. When you personalize something, you create the understanding and connection to the issue. Next slide. So this is a map that many of you have seen of the state of Wisconsin. It's important to recognize that this isn't happening in just one county or one area of our state. Wisconsin has participated in the SUID case registry since 2013 in an effort to gather as much data on the risk factors and circumstances that lead to these deaths. In 2016, 62 Wisconsin infant deaths were considered SUIDs, sudden unexpected infant deaths. All 62 of these deaths occurred while the infant was sleeping or was in their sleep environment. Of those 62 deaths, they fell into 2 categories. 77% were undetermined, and 23% were due to asphyxia, due to infant's position, other objects in the sleep environment, or overlay by another individual. In looking at our community data right here in Milwaukee, you can see that between 2015 and 2017, the number of infants who died in the sleep environment after being discharged from a hospital doubled. Alarmingly, 69% of these infants were exposed to secondhand smoke, and 8 in 10 of these infants were sleeping with pillows or blankets in their sleep space. The data piece that speaks the most to what our work needs to focus on in educating families is that 7 in 10 of these infants were placed on a surface not recommended for sleep, nearly 1/2 in an adult bed. Factors in the city of Milwaukee, such as unemployment, neighborhood deprivation, high crime and incarceration, and inadequate housing all contribute to poor health status and outcomes. In order to reduce the number of unsafe sleep-related deaths among Milwaukee's youngest, smallest, and most vulnerable residents, interventions with this population should focus on improving individual behaviors around smoking and safe sleep, improving their access to medical care, and especially related to preterm birth, and reducing life stressors that were mentioned above. Next slide. We consistently look at the state and community data and acknowledge that there is clearly a gap in parents understanding the importance of safe sleep, which drives our purpose in all of this, as we know we have an impact on them when they're in our hospital. Each of these bullet points that I'm going to go through above represents an event that has happened within our walls. And by acknowledging that these are real events happening in our institution, it drives the need to change our culture and educate our staff, because they are one of the most influential role models to these parents in our communities when it comes to safe sleep. So for the first one, we had a mom who fell asleep with the baby in her arms. The alarm for low respiratory rate caused the nurse to enter the room to find the baby between the side of the arm of the chair and mom. We also found a mom asleep with the baby under the armpit with a blanket covering the entire infant. When the blanket was removed, the infant had formula coming out of the mouth, not on a monitor. We also had a nurse who did an admission assessment and screening where we asked a question about their safe sleep environment at home. This conversation with the family did facilitate a Crib for Kids referral, and the baby, it came to find out that the baby had been sleeping in a dresser, and mom and the 2-year-old had been sleeping together in their bed. Another thing we saw was that mom had fallen asleep breastfeeding in a chair and dropped her baby on the floor. We had another incident where the nurse entered the patient's room and found the baby awake and fussing, lying on the floor at the foot of the parent's cot. And finally, we had another incident where mom threatened to leave AMA if we didn't let her baby sleep with a fleece blanket. So these are all real issues that our staff currently face on a daily basis with our infant population. Through education and coaching by our champions, we're able to prepare them to watch for these things and give them tools and scripting and how to work through these scenarios with the families. Next slide.
So in this next section, we're really going to share our journey with you. Knowing how important this is to the organization and the world, that's why we do this work. So we're going to go over the history of how we got to where we are, talk about how we had to revitalize the program, and then share with you how to create awareness and encourage improvement. So a little background. Prior to 2010, safe sleep was only practiced in the NICU. It was an NICU-specific policy. You can go to the next slide. And in 2010, as the policy owner, we decided to make the policy become organizational-wide. When that policy went organizationally wide, we also developed a interdisciplinary, interfacility, and community team of people who are going to take and implement safe sleep in all of these areas. We needed executive leadership support to do that, and quite honestly, we struggled in really getting compliance to where we needed it to be, despite many efforts, which I'll share with you. Over time, we've now condensed to be really just an inter-organizational team with an interdisciplinary team that's focused just on children. So way back in 2010, we used the influencer model to help guide our change practice. The model is about changing behavior to achieve measurable results. You change behavior by changing motivation and ability across personal, social, and structural aspects. So what do we do? From the personal lens, one of the things you have to address is what motivates people to do the right thing in relationship to safe sleep. So we shared hospital and personal stories. Under the ability portion of the personal category, it's really about giving staff the knowledge and skills to perform those vital behaviors. So we did online modules, gave them frequently asked questions about safe sleep, give them scripting for dealing with difficult families. In the social realm, it's about encouraging the right behaviors and encouraging them to do it. So we had BP webcasts, progress reports, leadership rounding, CNSs as champions, demonstrated appreciation. In the structural component of the influencer model, it's things to remind them to do the right things. We developed screen saviors, had display cases, shared audit data. In the ability end of the structural portion of the model, it's things to support them doing safe sleep practices. So we ordered sleep sacks, had to determine a laundry process for them. We looked at linen. We didn't have linen that fit our smallest cribs. Created web pages, had room cleans, developed a mission checklist, and developed teaching materials. And despite this work, we continue to struggle. So a few years ago, we did a revitalization of safe sleep in the organization. And we developed an education model that was rolled up for staff. We also encouraged providers to look at that model so that we could level set expectations and address barriers. And this is where we started our journey of the sleep champions. And we asked each unit to identify sleep champions and then went and trained all 27 of them, both here at our Milwaukee campus and also in Fox Valley. We presented again at various venues throughout the organization to create that buy-in and bring safe sleep back up to the surface. And most importantly, we asked each unit to work with their champions and their clinical practice and quality practice groups to develop individualized action plans, because we knew that each unit had struggled with different aspects of safe sleep. Next slide. So after we rolled out the module, we've been using some techniques to help boost that education. So we've strategized tactics to use over time. So we had to clean up the crib day to promote the bare crib that people don't like to have bare. They like to dress up with blankets, but that was a tactic to really get the cribs to be safe. Talked about the unit-based action plans. We had to order more sleep sacks because over our journey, the sleep sacks got destroyed in the laundry process. And we actually had to change vendors to make it so that they wouldn't get destroyed. Our Safe Sleep Champions took around a safety cart in August and talked about barriers with staff one-on-one. And then we had to look at linen one more time because our blankets in their current size did not fit some of our bigger beds and had to order that. From a communication vehicle, we had to go to multiple forums and share this message with many people. We have leader to staff feedback, we have peer-to-peer feedback, we engaged our provider staff, we use our internal webpage to communicate safe sleep, and we also talked about the use of volunteers so that we'd have people to hold crying babies. And most importantly, we really applauded the work of the culture change and the Safe Sleep Champions with recognition. And the strongest piece, I guess, is that our champions are so engaged and really engaged in developing those action plans. I think that's where we're going to get the biggest bang for our buck. And next slide.
One of our bid projects in 2018 was to redo our policy and procedure. We updated our policy and procedure to reflect 2016 American Academy of Pediatricians recommendations for safe sleep. The policy was reformatted. We added addendums and toolkits to the end of our policy, and we also created an escalation decision tree. When we reformatted, our old format had the addendums integrated with the policy, so we took those out and put them into a toolkit so important information was easy to find, and then the addendums were easy to find if people needed a particular document. It also includes a safe sleep for every sleep, not just bedtime. We're discouraging swings, infant seats, and other devices are not recommended for sleep and are okay for occasional use while baby is awake. Next is the escalation decision tree. This is a small sample of our escalation tree. It addresses challenges of staff and parent interactions, how to talk to a family when unsafe sleep practices are identified. The biggest thing is consistency among our staff, and then the provider supporting the safe sleep messaging. We do have some issues with providers bringing their personal beliefs into safe sleep, so this decision tree does help them. So to start, on admission, the RN educates families on our safe sleep practice. If the family is found unsafe, the RN re-educates the family and documents it in our electronic health record. They notify the charge RN. If the baby is found again in an unsafe sleep practice, the charge RN will go in and talk to the family, and then we escalate as needed with the unit manager, social work, patient care manager on call if it's after hours, and security as well. We have used the escalation tree several times in our facility. When families cannot adhere to our guidelines, it can result in the hospital telling the family that they are unable to stay overnight with their baby and are only allowed during normal visiting hours. Next, we're going to talk about the tenets of safe sleep. The tenets of safe sleep are alone, on their back, in a crib. So the 2016 AAP guidelines recommend room sharing, but not bed sharing. Infants should be close to their parents, but in a separate safe sleep area, portable crib, or bassinet. They recommend alone. Side and prone are no longer recommended by the AAP. Lying flat on the infant's back does not increase the risk of aspiration. Alternative sleep positions are acceptable once the infant can roll themselves. Everybody's aware of the ABCs, but we tend to forget some of the other tenets of safe sleep. Firm sleep surface with a tightly fitted sheet, free of soft objects, blankets, toys, loose bedding, bumper pads. Having your house set at a comfortable temperature, swaddled in a single cotton blanket, or the use of a sleep sack. Do not use fleece as it prevents air exchange and can cause overheating in the infant. Breastfeeding your baby is recommended and is associated with a reduced risk of SIDS. Infants should not be fed or held on a soft couch or recliner if falling asleep is highly likely. Feed the baby in a well-lit room to avoid falling asleep. Pacifiers are recommended during sleep by the AAP unless contraindicated by the baby's medical condition. A smoke-free environment, 69% of our community deaths, the babies were exposed to secondhand smoke. Avoid products that go against safe sleep recommendations, especially those that claim to prevent or reduce the risk of SIDS. Products, and then also do not use heart or breathing monitors. These products don't show evidence to support that their use will decrease SIDS. And then lastly, tummy to play, back to sleep. So in our development of our Safe Sleep Champion process, we did construct a timeline and plan for the champions and gave them a contract to sign and acknowledge their role as a champion. I'm going to jump a little bit around on this slide, but so for the training, after spending about a year as a committee, we got organized and planned for the champion process. We did reach out to the unit leaders, as I had said earlier, to identify someone on their unit with an interest in the topic. We did have a lot of interest, and after we recruited those names, we created a 3-hour training for the champions, which was composed of a mix of lectures, scenarios, and role-playing. Different things that we had at this training, we had a crib set up with different items and had the champions practice doing an audit. We had scenarios developed for them to practice using the escalation decision tree. So those were all kind of things that we wanted them to practice before we set them out to do on their units. Part of the training was also around learning how to coach and communicate on their units to help with the facilitation of culture change. So we did spend some time on this. And then in addition, the champions were asked to do 10 safe sleep audits per month and round with staff on safe sleep, as well as attend a monthly meeting. Especially during the first few months, we spent a lot of time in our monthly meetings talking about barriers that the champions were running into during the month prior when they were auditing and rounding. So we did spend a significant amount of time listening to the barriers that they were running into as they were coaching, and I think having these meetings with them really helped to kind of bring out things that we needed to focus on as a group as well. Once they were comfortable in their role after a few months, some committee members then did attend the Champions Unit Partnership Council meeting with the champion, and we presented the individual unit's current compliance with their audit data. We then asked the champions to work with their partnership council in determining an intervention and action plan that they could implement to increase their compliance. Each unit did have different sets of barriers, therefore we didn't standardize the intervention across the house because we knew that one intervention wasn't going to solve all of the issues. We knew that there were specific things that each unit had to work on because of our patient population. Next slide. Prior to the training of the champions, we, in 2017, had about 200 audits that were done, and then in 2018, we had almost 800, and with still 3 months of audit data to complete, we've already had about 1,500 audits this year. So we've had great buy-in by the champions to complete the audits. And I will say having that data has really helped us focus what our intervention should look for. So the audit has gone through several versions, as we had initially just been auditing for items in the crib, such as blankets, burp cloths, stuffed animals, things of that nature. But once we had the champions trained and felt that they were ready, we did add additional pieces to the audit because we felt that all facets of safe sleep should be looked at in the hospital to determine if there were positioning or sleep location issues, which we did find out were prevalent. So we did have the audits they are entered into our internal reporting system by the champions, and the data is compiled monthly and shared with staff. One barrier we ran into initially after our audit process was our populations of babies in critical care who, per our policy, would be considered an exception to safe sleep due to their condition, benefiting from alternate positioning, including prone. There was a big push to bring awareness to these areas that just because the baby is critical and maybe can't be on their back does not mean that all facets of safe sleep should be ignored. So we really worked with these areas to have their crib clean and not have blankets in there because because they were an exception to that piece of it, we wanted them to know that not every piece of safe sleep needed to not be followed. But this was a big education opportunity with these areas. Next slide. So this is an overall graph of our 2019 safe sleep compliance in our hospital. It isn't great, being completely transparent. You can see that in February of 2019 is when we trained our champions. We did initially expect our compliance to go down because now that we had all of the champions, we had more people looking, and the more you pay attention to something, the more you find of it. So we did anticipate to see it go down. This is a journey and it's not a quick fix, and we really acknowledge that when we started out with this additional push. Our goal is to sustain 90% or greater, and again, personalizing the numbers, we have to remind staff when we show our data that anything below 90% represents audits done on someone's son or daughter who wasn't in a safe sleep environment, and that's what we're role modeling for them. Next slide. So once the audit process was in full swing, we did rely heavily on the data to really guide our overall hospital interventions that we could have influence over and work to make changes. As Anne had mentioned earlier, linen, prior to our rollout, we had some challenges with linen, improperly fitting crib sheets, different items of that nature. So we really had to make sure that we focused on changing these things for staff. We knew that that wasn't something that was unit specific. It was something house-wide. So as a committee, we did work on the linen process. For the thermal regulation and the use of hats, what we found in the auditing process was that hats were sometimes lying somewhere in the crib, sometimes over the infant's face after they have fallen off their head. And we used this as an opportunity to educate staff on the risk of overheating infants and reminding them that hats should be removed as soon as thermal regulation has been achieved by the infant and not worn at other times. So this was an opportunity that we kind of changed our view on as well. We did also struggle, as Anne had mentioned, immensely with our sleep sacks. I know other hospitals have mentioned this as well with other venues that I've heard. The availability sometimes was a challenge. Sometimes we were short on some units, we didn't have enough. Additionally, the laundering process created quite an issue with our sacks for a period of time, often melting the zippers or buttons and making them unusable after washing. There was a significant amount of effort that went into, changing the vendor, but, these are all tactics that, took time to change. It wasn't something that we could do overnight. We did figure out the laundering process, but since having the champions, they've also identified that there is a sizing issue with the sacks, that sometimes parents want to put a blanket in the bed because the sleep sacks that we have are sleeveless, or the sacks that we have are too small for the bigger size babies that we have. So we continue to work through those challenges, and one thought is having a consistent long sleeve onesie t-shirt for the bigger babies. But these are all things that, we want to look at as well. For family and cultural influences, this has been something that we are challenged with on a regular basis as well. One example I can give is we recently had a family that was insistent that the infant's grandmother's ashes in her urn be in the crib at all times. And this was a tough conversation to have with the family. But knowing how to have the conversations is crucial to making sure that we have an open line of communication. Certain cultures have a desire for comfort and warmth for their infants. It's hard to say that the beautiful homemade blanket that grandma made can't be in the crib with the baby. But again, having those conversations and making sure that they're interactive between the parents and us, and not just saying, you can't do it, but making sure that you're having a good conversation around that. We have to find the balance of remaining culturally sensitive to these families while still conveying the information regarding safe sleep and having an interactive conversation with the parents, the caregivers, and the leaders on the unit. Having everyone in the room for that conversation, we have found is really helpful. That way the nurse doesn't feel like she's just, saying that this is something that she believes or, it's policy. And having an interactive conversation we have found to help with some of these cultural differences. We are able to share evidence that we know and discuss the risk reduction of behaviors for the families, so that they can adopt that. So it's important to share the evidence with these families. We also have a document available to all staff on our intranet, and it's a great document. It's from the National Institute for Children's Health Quality around tactics, and it has examples to support safe sleep conversations. The document is primarily based on cultural and family preferences, and it has a lot of scripting, which has been very helpful for all the different scenarios that you could run into. Also, using our audit data showed us that we have many different items in our baby's sleeping environment. Through doing the audits, the data allowed us to narrow down by unit which items they're struggling with. So one unit we found had a big struggle with having extra blankets in the crib because their babies were spitting up frequently, and so they were putting blankets underneath the baby so that they didn't have to change the crib sheet every time. But other units didn't have that culture. So it was really important that we use the data to look at where certain areas were struggling. And then finally, supporting those crying babies. It continues to be a challenge for us. We have nurses with multiple patient assignments who will often put their babies in swings, which does soothe them and often puts them to sleep. The culture change we're working on is then moving these babies to their crib once they are asleep. Again, acknowledging the impact of the stories that we've seen. We've tried to be creative and work with our volunteer services and increasing the number of volunteers available to hold our babies as one intervention that could help with this. Next slide. And then prior to our education rollout to our staff, we did ask staff to write down what they identified to their barriers of promoting and following safe sleep in the hospital. These were some examples of what they did write down. The first one, someone had said parents are going to do what they want in the home setting regardless of what we teach in the hospital. And so what we found through that is that we needed to spend time coaching the champions and staff and how to have those interactive conversations with parents and educating them on the vital role that they play in modeling the right behavior regardless of what the parents do in the home setting. We still need to be that role model. For lack of consistency, we found that this was a challenge across the board. Many of our champions would tell us at our monthly meetings that they struggled when a patient was transferred from another unit who had been on that unit for a period of time. On that unit, maybe they were allowed to have things in their crib, and then they come onto their unit and they have to tell the family that they can't have those items anymore. This did create an uncomfortable environment for staff, and we had to figure out a way to become consistent. And it wasn't always unit to unit. Sometimes it was even shift to shift. So it was stressing the importance with staff that, we have to be consistent with our messaging with our families. For swings and bouncy seats used to get kids to sleep in the home and the hospital, I talked about the swing issue previously. There continues to be that resistance that why would I want to move a sleeping baby in a swing back to a crib? But again, we have to communicate, the dangers of leaving that baby in the swing. And then the current products on the market that enhance safe sleep, we really need to spend time educating parents on these. Unfortunately, these products all enhance sleep, but they don't enhance and promote safe sleep. So, anyone can Google things. You can find pillows for infants that will decrease their flat heads. You can find $1,000 bassinets that promise to boost a baby's sleep by combining gentle rocking with soothing white noise. You can find sleepers that market the ability to lull fussy infants into a peaceful slumber. None of these products address the risk to the infant, which is challenging to new moms who see these things on the market, and why wouldn't they want a product to boost their baby's sleep? So it's really important that we address these products with the families so that they understand that there is risk with them. And then finally, the promotion of co-sleeping by other organizations and other countries. Staff did identify this as a barrier when they're trying to promote co-sleeping within the hospital, and there's other countries' data that show that they do co-sleeping. This exercise that we did with the staff also surfaced some personal beliefs by staff and providers and came out as an additional barrier, as we did have some staff and providers who have said that they've co-slept with their babies at home and their babies were fine after doing it. So we did have to really message to the staff that we have to stay consistent and that we have to follow our hospital policies while we're at work, but it is challenging when you have those. It is helpful. We do have risk management that sits on our committee, on our Safe Sleep Committee. They have really helped with some of these concerns that we've had and working with staff around that as well. Next slide.
So strategies, what can we do and how can we improve our environment? We've talked a lot about our linens. We know that untucked blankets and cloths can increase the risk of suffocation. So we now have the larger blankets here that can be tucked on 3 sides, both sides and the foot of the bed. And they're large enough even for our biggest beds here at Children's. Sleep sacks, again, knowing that overheating and over bundling pose an increased risk. We do have the sleeveless sleep sacks, and the babies can wear a long sleeve t-shirt underneath. I think other sleep sacks that are available are the kind with wings that can be made for bundling, can be used for bundling, and those are just fine as well. We'd like to also point out that prenatal teaching is essential. Providers should be sharing the safe sleep message early on so that parents and families can make a safe sleep plan. So when they get home, they have an idea of how they're going to work to promote safe sleep. In the NICU, we have a tool which we call the Safe Sleep Wheel, and it's at the bedside of each patient. And it turns, and it's a great visual for staff and parents. It shows the current state of the baby. So, for example, if our baby is intubated, and has a breathing tube and is not going to be in safe sleep, the little wheel turns to expose that part of the pie. When the baby is in safe sleep, there is a portion that says, I am in safe sleep alone on my back in my crib. There's an excellent board book out on the market. It's called Sleep Baby Safe and Snug, which promotes and provides a safe sleep message in a little rhyming way. It was written by Dr. John Hutton, who is a pediatrician, and he was commissioned by the parents of a baby named Charlie, who passed away from SIDS and was in an unsafe sleep environment. And I think we'll have a link later to Charlie's story. We know that we need to work on changing the culture and beliefs of our staff, and we know it won't happen overnight. But again, the staff must put their own beliefs aside and promote the safe sleep practices here at Children's according to our policy. And then a little bit more about our Safe Sleep Champions. They customize unit action plans based on the barriers that they were seeing on their own unit and shared with their staff. And they have become really the go-to resource to provide this safe sleep practice here at Children's. Another thing that we noticed was that we needed to standardize our educational materials throughout the hospital for our families. So we did do that. We have had all of the nursing staff complete an education module. And wouldn't it be great great if we could educate all staff here at Children's, the therapists, even down to the environmental services staff who may be in the room cleaning the room and notice that a parent is sleeping holding a baby, so they could alert us. Next slide. So education for families. We have different ways of educating families and parents. We all learn differently. We have posters and teaching sheets which describe the ABCs, which is an excellent visual, a very simple alone on your back on a crib and a picture of a baby alone in a crib on his back. The teaching sheets show safe and unsafe sleep images as well. And then we also have a teaching sheet that talks about tummy time and how to balance tummy time with safe sleep, because we want our babies also to learn to strengthen their neck and back muscles. And so tummy time is very important, but how to balance that with safe sleep is huge. We also discovered that on admission, when we asked if the parents had a crib, we changed the wording a little bit to "where will your baby sleep?" And that is now a documented piece in EPIC where that information is recorded. We also have videos for parents to watch. A couple of them, one is called Safe Sleep for Your Baby, and the other is Safe Sleep for Grandparents and Other Caregivers. And we strongly encourage our parents to watch those before they go home. And then again, we just talk about ABCs with them. We use Teachback and we assess their knowledge and see if we need to have any more follow-up teaching before they go home based on our conversations with them. We are all obligated to be role models, and it is essential that we practice this. Again, if a family is gifted a homemade fleece blanket and they really want to use that, we just have to have that conversation with them. And hopefully our education will help them change their tactics. We can also show parents other ways to soothe their baby. They may need to be taught how to rock or pat or playing music, using a fan or some white noise. Any of those things can help soothe the baby to sleep. And then this slide just shows two of our teaching sheets, the ABC with excellent visuals there, safe and unsafe practices, and then our back to sleep, tummy to play, and why that is important to balance safe sleep as well. And then additional resources for our staff. We have on our intranet, the next slide, I'm sorry, shows our Safe Sleep page within our children's intranet, and it defines safe sleep and unsafe sleep, and then it has links to all the resources that we have for our families. So we have safe sleep videos in Spanish and English, helping a baby to get back to sleep, concerns about choking, and then we also have new now our Discover Children's app, which parents can also find resources on safe sleep. And we also have a video message from our Chief Medical Officer, Dr. Goodsight, with a safe sleep message for families. And then additional resources on the next slide show cribsforkids.org is a great program, the Halo Sleep Stack program. You can find out how to get sleep stacks available for your hospital. We have parents' testimonials on YouTube that really talk about real life events, and one may think this won't happen to me, but these are real true stories of parents that have lost their child due to safe sleep practices or SIDS, And one of the stories is about Charlie, which was the inspiration for the book, Sleep Baby, Safe and Snug. The NICHQ, the National Institute for Children's Health Quality, is another resource hospitals can use to support safe sleep strategies. Of course, the AAP, American Academy of Pediatrics, and Children's Health Alliance is an alliance housed within children, and they develop innovative child health initiatives in partnership with the Wisconsin Department of Health Services. And they also implement programs that have been proven to impact access and outcomes. And then the National Institute of Health is another great resource, the NIH. And next slide.
So we have shared our journey to change the culture of safe sleep here at Children's, thereby achieving our vision of the healthiest kids in the country. Our wisdom to use to perform your own current state assessment of how you align to the tenets of safe sleep, education, and role modeling to families. You may wish to review or create a policy to provide structure to set expectations. Standardize your educational materials. Safe sleep materials are in abundance on the web. Staff will need direction in order to provide that consistency that we spoke to. You may want to consider creating a website to house those resources. Monitor your own media for unsafe sleep photos. We've had several instances here at Children's where we have found not intended breaches in safe sleep, but used as advertisement where kids were in unsafe sleep, either with blankets in the crib or dad and a baby sleeping together. And really making safe sleep visible for families and teaching them the strategies to get their baby to sleep so they don't use devices designed to put babies to sleep, but not to safe sleep. Next slide. So safe sleep is a priority for everyone. Everyone needs to be a champion. Role modeling is essential. Stories are powerful if you want to change your culture, but changing culture is very difficult. Our thinking that guides our behaviors, which impacts results, is important to think about when we're talking about changing culture. We need to have standardized resources in education as well as level set those expectations. Most people understand the tenets of safe sleep, but they honestly believe it won't happen to me. I was recently at my hairdresser's and she was talking to me about her 4-month-old who was sleeping with a blanket and refused to not sleep with the blanket and she was finding the blanket on top of his head. I shared with her a story of a colleague that someone shared here where she was alerted that her baby something was wrong because her dogs were barking in the baby's room and her baby was suffocating with a blanket. The good news to that story is that baby was fine, and I shared this with my hairdresser, not to scare her, but to really say this really does happen, so that we can keep our babies safe. Every interaction with a mother has within the healthcare system, whether during pregnancy, delivery, or postpartum care, is an opportunity to discuss sometimes conflicting information available to families and to reinforce safe sleep practices and breastfeeding messages both vocally and visually. Thank you so much for having us here today. What questions do you have for us?
Okay, yeah, let's look at our any questions. I don't see any at the moment that have come in. We do have a few minutes here left, so please feel free to write in your questions, or feel free at this time to raise your hand, and I can take you off of mute, and you can discuss or ask any questions that you would like to. I just want to thank the speakers for sharing your story of the journey and the revitalization and the program for safe sleep, modeling safe sleep at Children's. We really appreciate the honesty and transparency that you presented here today. I think it's really important for everyone to see the difficulties and the barriers that of changing culture, really. Regarding safe sleep practices. So thank you again to all of you. Do any of you have any other things you wanted to add, or just some last words, or any advice out there for the audience for folks who maybe are trying to do similar efforts in their hospital?
I think the only thing I would mention is to try not to start from the beginning. There's a lot of hospitals that are willing to share their policies, really try to use those resources instead of starting from the beginning. I think that really helps, and it's not as overwhelming.
Sure. Great. Yeah.
I'd be curious what people are struggling with currently.
Yeah, please. If anyone would like to share any issues with or surrounding safe sleep that you're struggling with in your own facilities, feel free to share that with us and at this time. Okay, we do have a question that came in. How did you get buy-in from hospital leadership to see the importance? It's a good question. Thank you, Karen.
I guess we're gifted to have some vice presidents that really appreciate the importance of safe sleep, and we're on board from the beginning, even way back in 2010 when we transitioned the policy from being NICU-centric to house-wide. We got commitment right away from our hospital VP as well as our VP of community services at that time, because they really wanted to impact the safe sleep messaging and work in the organization.
So it sounds like it was not a tough sell for them. That's great. Yeah. And
that when they see the data in our community and the amount of infant deaths that we have in the community, I think they realize that we can play a role in that. So I definitely think showing the numbers and sharing those stories also helps acknowledge that it is an issue.
Right. No, that's great advice. Definitely. Wonderful. Yeah. Well, if anyone has any other, we have a couple more that came in here. So Amanda is asking, share how new staff trained during onboarding. So brand new, I think this is getting at how brand new staff were trained on safe sleep during their onboarding process. And did that?
We created
go ahead.
Created a module that is required for all new staff that talks about safe sleep and what we've worked on so far and what the expectations are. And all of them are required to review that module as part of their onboarding.
Okay. Thank you.
And then just so whoever is precepting them, if they encounter an unsafe sleep situation, just addressing it with the new hire, giving them tactics on how they would talk to the family, even just the preceptor talking to the family that time so they can hear how a conversation might go.
Sure. Right, just modeling how to have that conversation that can be tough for a new staff, I'm sure. So having that preceptor be able to model that would be really helpful. Okay, well, thank you for the great questions, everybody. We do have a couple minutes left. If anyone has any other questions or discussion points that you'd like to bring up, any stories or anything, feel free to share that. I will go ahead and kind of start wrapping things up here. I just want to give you a few reminders that if you were watching in a group today, please make sure that you email that attendance list. So just a list of first, last name, and email addresses to us. In no special document or anything like that, just make sure that we get those names and email addresses. Reason being because we want to make sure that everyone who would like continuing education credit does receive it, and so we need to send that via email. And the other reason is because we really do need to know for our accreditation purposes how many folks were out there listening and watching this webinar. So please make sure to let us know that if you were gathered in a group watching this. We would really appreciate that. And just watch for that that email with your a link to a survey that has the evaluation contained in that. Your continuing education certificate will be sent via email upon completion of that evaluation. We did record the session today, so that will be available to those who registered but were not able to attend. We will certainly get that out. So if you have any colleagues that you know plan to attend but were not able to, for whatever reason, we will have that link out to them here shortly. And if you're not a member of WAPC, we highly, highly encourage you, of course, to join. Not only do you get discounts on on your conference registration, your annual conference registration, which we hold every spring, but also on all kinds of in-person and webinar events as well. And in addition to that, being a member of WAPC is really just identifying and standing with the mission of WAPC to improve perinatal care across Wisconsin. And so if you believe in that as much as we do, we really want to welcome you into our family of multidisciplinary perinatal caregivers across the state. And it's a great network of experts that you can have access to. So we just want to, highly encourage you to do that. So thank you again to Children's of Wisconsin for helping us out with this webinar today, all four of you, for sharing your loads of expertise with all of us. It's so important. So thank you very much, and thanks all to you for attending this webinar today and listening out there. Thank you.